Hi guys, welcome back again. In this video I'm going to be covering acute coronary syndrome. Okay, so acute coronary syndrome is a term that encompasses both unstable angina and MI. So unstable angina is characterized by new onset or rapid worsening angina. So angina on minimal exertion or at rest in the absence of myocardial necrosis. So MI is different from the unstable angina by since there is evidence of myocardial necrosis. So the term of acute MI should be used when there is evidence of myocardial necrosis. Okay, in a clinical setting consists with myocardial ischemia. So about the acute coronary syndrome may present as a new phenomenon in a patient with no previous history of heart disease or chronic stable angina. So now let's focus on pathogenesis. Okay, acute coronary syndrome is almost always occur in a patient with atherosclerosis. So these vascular changes during an acute coronary syndrome are dynamics, such that there is the degree of obstruction either increased, leading to complete vessel occlusion, or regress due to effects of platelet disaggregation and endogenous fibrinolysis. So in an acute MI, occlusive thrombus is almost always occur at the site of rupture or erosion of an atheromatous plaque. So without treatment, artery responsible for the MI that remains permanently for occlusive in 20 to 30% of patients. So now let's focus on clinical feature. But before that, I'd like to tell you about the differential diagnosis. Why? Because it's very important, and in the differential diagnosis in acute coronary syndrome is wide and include most causes of central chest pain and or collapse. So differential diagnosis of central chest pain include cardiac, pulmonary embolus, aortic causes, esophageal causes, mediastinal causes, and emotional. So let's focus on cardiac. Cardiac, we have myocardial ischemia, angina, myocardial infarction, myocarditis, pericarditis, mitral valve prolapse. Okay. About the aorta, we have aortic aneurysm and aortic dissection. About the esophageal, we have esophagitis, esophageal spasm, and Mallory syndrome. About the mediastinum and emotion, in the mediastinum there is only malignancy in the diffusion. Okay, so central chest pain at rest is cardinal feature, but breathlessness, vomiting, and collapse are also common feature. So the pain occurs at the site of angina, okay, but is usually more severe and lasts longer. So described as a tightness, heaviness, or constriction in the chest. So most patients are breathless. Well, in some patients this is the only symptom. Okay, so painless or silent MI may occur. Okay, particularly common in older people and those with diabetes mellitus. So if syncope occurs, is often due to or what you call caused by arrhythmia or profound hypotension. Okay, so vomiting and sinus bradycardia is often due to vagal stimulation. Okay, are common in patients with inferior MI. Okay, so may infarction occurs in what we call in the absence of physical signs. Here we have specific complication of acute coronary syndrome, or what you call the first one is arrhythmia. Arrhythmias are common complication of acute coronary syndrome, but the risk of arrhythmia can be minimized by adequate pain relief, rest, and correction of hypokalemia. So here we have some of arrhythmia which is common, such as ventricular tachycardia, ventricular fibrillation, atrial tachycardia, atrial fibrillation, atrioventricular block, and sinus. So the second one is recurrent angina. the first one, as I mentioned, is what we call arrhythmia. The second one is recurrent angina. So the patients who develop recurrent angina at rest or minimal exertion following an acute coronary syndrome are at high risk, so should be considered for prompt coronary angiography. This is the second one. The third one is pericarditis. So the fourth one is Dressler's syndrome. Dressler's syndrome, so it's characterized by what we call persistent fever, pericarditis, and pleurisy. The fifth one, we have acute heart failure, okay, due to extensive myocardial damage. And another, the sixth one is what we call papillary muscle rupture. The seventh one, we have ventricular septal rupture. The eighth one, we have ventricular rupture. The eighth one, or the last one, we have what we call embolism. So that's about complications. Let's focus on investigations. In the investigations, we have ECG, cardiac biomarkers, radiography, chest x-ray, okay, should be performed. Why? Because this may demonstrate pulmonary edema, which there is no evidence of in what we call clinical examination, okay, so should be performed. And the fourth one is echo, and the fifth and the last one is coronary angiography. Okay, let's focus on ECG. It is central to confirm the diagnosis, but may be difficult to interpret if there is bundle branch block or what we call obvious myocardial infarction. So, the earliest change on ECG is ST segment elevation is seen initially. The later diminution in the size of R wave, and then in transmural or full thickness infarction, development of Q wave subsequently. So the later T wave becomes inverted. Why? Because there's change of what you call in the ventricular repolarization. This change persists after ST segment has returned to normal. Well, in non-ST segment elevation of acute coronary syndrome, there is partial occlusion of major vessel or complete occlusion of minor vessel, okay, that causing unstable angina or partial thickness MI, what you call subendocardial. This is usually associated with change in what we call ST segment depression, and T wave changes in the presence of infarction may be accompanied by some loss of R wave and of what we call absence of Q wave. Okay, if there has been anteroseptal infarction, the abnormalities are found from V1 to V4. Okay, from V1 to V4. While anterolateral infarction abnormalities are found from V4 to V6, and in AVL and lead 1. Okay, AVL, lead 1, V4 to V6. While the inferior infarction is best shown in what we call lead 2, lead 3, and AVF. Okay, so if there is what we call infarction of the posterior wall in the left ventricle, doesn't cause ST elevation and Q wave in the standard lead is so well, but it can be diagnosed by what we call ST depression and tall R wave in lead V1 to V4. Okay, that's about ECG. And what about cardiac biomarkers? A measurement of the serum troponin should be taken. Okay, serum troponin. Well, radiography, as I mentioned, chest X-ray, and the others is what we have called echocardiogram. Okay, so it's normally performed before discharge from the hospital. It's useful for assessing the ventricular functioning and detecting important complications such as mural thrombus and cardiac rupture. And the last one is coronary angiography. Okay, let's focus on management. In the management, if there is no complication, no risk factors, show that angiography isn't required. Okay, so the patient can be mobilized from second day and discharged after 2 to 3. Okay. In the management, we have analgesia, reperfusion therapy, thrombolytic therapy, antithrombotic therapy, lipid lowering therapy, smoking cessation, diet and exercise, and what we call renin-angiotensin blockade, and the last one is anti-angina. Okay, let's focus on analgesia, the first one. Analgesia is essential not only to relieve distress, but also to susceptibility to ventricular arrhythmia. IV morphine sulfate 5 to 10 milligram should be administered. Okay, this is about analgesia. And what about reperfusion therapy, the second one? Immediate perfusion therapy or immediate perfusion with PCI is indicated when there is ECG shows a new bundle branch block or ST segment elevation in two contiguous leads of 1 millimeter or more in limb leads or 2 millimeter or more in chest leads. So successful therapy is also associated with rapid pain relief. Okay, that was about analgesia and reperfusion. What about thrombolytic therapy? If the primary PCI can't be achieved in a timely manner, so thrombolytic therapy should be administered. Okay. The fourth one we have antithrombotic therapy. Oral administration of 75 to 325 milligram of aspirin daily improves survival. So the first tablet, 300 milligram, should be given within the 12 hours. Okay, that's about the thrombotic or thrombolytic therapy and antithrombotic therapy. On the other hand, we have anti-anginal therapy, such as sublingual glycerol trinitrate 300 to 500 microgram is valued. First aid measure of unstable angina or threatening infarction. And also we have IV nitrate is useful for treatment left ventricular failure. Okay. Also we have renin-angiotensin blockade such as long-term AC inhibitors like enalapril 10 milligram twice daily is useful for prevent new onset of heart failure. Okay. Also we have lipid lowering therapy, smoking cessation, and diet and exercise. Okay, so that's all about acute coronary syndrome. Hope you get a benefit from this video. Thanks.